Hello, I'm Miriam Anderson from the Department of Health and Human Services, Office of Inspector General, or OIG. A top priority for OIG is to protect the health and safety of HHS beneficiaries. To do this, we leverage a multi-pronged approach. First, we focus on exploring opportunities to improve the efficiency and effectiveness of HHS programs. Next, we work to hold those engaged in fraud accountable for their actions. And finally, we empower and collaborate with partners through data sharing and education. This short video provides an overview of a toolkit OIG released to assist its partners address the opioid crisis. The toolkit is based on OIG's own analysis of Medicare Part D data and provides instructions that allow others to replicate our analysis. OIG first developed the methodology of the Opioid Analysis Toolkit in 2016 to track opioid use in Medicare Part D. Once developed, we recognize the value of making the toolkit available for broader use by public and private sector partners. Each user can leverage the toolkit to analyze their own prescription drug claims data to identify patients who are at risk of opioid misuse or overdose. The toolkit includes step-by-step instructions, a detailed description of programming code in 3 different programming languages, SAS, R, and SQL, and an overview of the types of analyses possible using the toolkit. Users can modify the code to meet their unique needs, such as identifying patients at varying levels of risk. The toolkit allows users to quickly analyze large amounts of data. The data can then be used to identify strategies to improve coordination of care and inform program integrity. To provide context around what the toolkit can do, I'd like to explore a recent data brief OIG published in August 2020. In the data brief, OIG used methodology from the toolkit to analyze opioid use in Medicare Part D in 2019. It was the 4th in a series of briefs that monitored the progress of Medicare Part D in addressing the opioid crisis. Specifically, we found that in 2019, nearly 267,000 Part D patients received high amounts of opioids, and of these, almost 34,000 beneficiaries were at serious risk of opioid misuse or overdose. Each of these beneficiaries received extreme amounts of opioids or appeared to be doctor shopping. Although this number decreased from the previous 3 years, it is still concerning. It may signal that a beneficiary's care is not being monitored or coordinated properly, or that a beneficiary's care needs to be reassessed. It may also indicate that a beneficiary is seeking medically unnecessary drugs, perhaps to use them recreationally or to divert them, or that a beneficiary is at risk of overdose. We also found that 140 prescribers had questionable opioid prescribing. They each ordered opioids for a high number of beneficiaries at serious risk and warrant further scrutiny. Ordering opioids for a high number of these patients may signal that a prescriber is not checking state prescription drug monitoring databases, or that the prescriber is ordering medically unnecessary drugs that could be diverted for resale or recreational use. Another possibility is that the prescriber's identification was sold or stolen and is being used for illegal purposes. To identify the patients flagged in this data brief, we analyzed the Medicare Part D claims data from 2019 and calculated each patient's opioid level. We used a measure known as morphine equivalent dose, or MED. This measure is also known as MME, or morphine milligram equivalent. MED is a standardized measure that represents the potency of the opioids a patient is receiving. As you may know, opioids vary in strength. A 30 milligram tablet of oxycodone is far more powerful than a 5 milligram tablet of tramadol. The MED calculation takes this difference into account when determining the patient's total opioid level. This is particularly important if a patient is taking multiple opioid prescriptions at the same time. Using the MED calculation, we identified patients receiving high amounts of opioids. We considered a patient to have received a high amount if they had an average daily MED that exceeded 120 milligrams for 3 months. This 120 milligram threshold is higher than the Centers for Disease Control and Prevention's recommendation that prescribers avoid increasing dosages above 90 milligrams. We also identified patients who were receiving amounts we considered to be extreme. We considered a patient to have received extreme amounts if they had an average daily MED of 240 milligrams for an entire year. Finally, we identified patients who appear to be doctor shopping. These are patients who received high amounts of opioids and had 4 or more prescribers and 4 or more pharmacies. So how can you use the toolkit? The toolkit includes step-by-step instructions for using our programming code to conduct analysis on your own data. You can then use the resulting data to track the progress of your program in addressing the opioid crisis or to inform your care coordination or program integrity efforts. Before we end, I'd like to share an overview of the actual elements of the toolkit. There are 3 sections: an explanation of the opioid analysis, an explanation of the code to conduct the analysis, and then the programming code itself. The first section of the toolkit outlines the specific opioid claims data you need to run the analysis and provides guidance for merging data for the MED calculation and conducting quality control checks. As illustrated in the data brief just discussed, the toolkit code can identify at-risk patients, including patients who had high amounts of opioids prescribed, patients who had extreme amounts of opioids, and patients who appear to be doctor shopping. As previously noted, depending on the purpose of your analysis, the code can be changed to identify patients at different levels of risk. For example, the threshold MED can be modified to identify patients at higher or lower levels of risk, depending on your needs. The last component of the toolkit is the programming code, which is available in 3 different programming languages: SAS, R, and SQL. You are able to download these codes directly from the OIG website. Again, the criteria to identify different at-risk patients may be customized in the code. Notations are included in the code to indicate where these changes can be made. Collaboration with partners, including data sharing, is an important component of OIG's efforts to aid in the fight against the opioid crisis. We are proud to share our opioid analysis toolkit and invite you to visit the OIG website to download the toolkit and the appropriate programming code to support your specific needs. There are 2 documents. One includes the SAS programming code, the other includes the R and SQL code. Both documents provide the same detailed descriptions of the analysis. Fighting the opioid epidemic remains one of OIG's top priorities, with the Opioid Analysis Toolkit a critical component in our efforts.